I'm happy to introduce our panel members today. We have Dr. Rana Saeed from UT Southwestern, Dr. Flippen from UCLA, Dr. Gable from Duke, Dr. Khan from Emory, and Dr. Sarva from Weill Cornell. Dr. Saeed, I'll turn it over to you.
Thank you. It's really gives me a lot of pleasure to be able to moderate this panel today with such wonderful colleagues on the Clinician Educator career path. I'm going to start with a quick introduction of who I am and what I do, and then I'm going to ask my colleagues, I'll ask them each in turn to introduce themselves. Please feel free to put questions in the Q&A, and we've got some kickoff questions to start. But everyone will be telling you a little bit about themselves and give a brief overview of their career path as a clinician educator. So my name is Rana Saeed. I'm a pediatric neurologist and epileptologist at UT Southwestern in Dallas. I have been the child neurology residency program director at our program for nearly 17 years. And my educator path really started by being open to possibilities. So I'm not going to get too much more into it other than I'd always loved teaching. And when the opportunity arose that they needed a program director, I was willing to roll up my sleeves, take a program that needed a little love and work, and to the place that it is today, that I'm very proud of it. So next, I'm just going to go by the person on my right. I have Dr. Flippen. Please tell us, introduce yourself and tell us about your career path.
Hi, I'm Charles Flippen, and thank you, Dr. Saeed. I'm the Richard and Ruth Walter Professor of Neurology in the Department of Neurology at the David Geffen School of Medicine at UCLA, where I serve as Vice Chair for Education and Residency Program Director. My path as a clinician educator began in part at the AAN annual meeting. As a junior faculty member, I was asked to serve on what was the annual meeting subcommittee, which was a committee that sat in a room for almost 36 hours straight planning this week-long education program. And also at that time, I began serving as a oral examiner for the ABPN, which I did for 15 years. So I've served as the third-year clerkship course director at UCLA, and then transitioned in my position as a residency program director. And I've been doing this now for about 8 years.
Thank you. Great path. Let's see, Dr. Sarva, I have you next.
Thank you, Dr. Saeed. Samharini Sarva. I'm an assistant professor of clinical neurology at Weill Cornell Medicine, trained in movement disorders. I think my path probably began in med school. I had just such wonderful mentors, and it was really encouraged in my current institution, where I'm director of the medical student electives. I run this. I'm the faculty advisor for SIGN, or the Student Interest Group in Neurology. I'm also a member of the undergraduate education subcommittee. So it's been really a fun ride so far. So looking forward to expanding on that.
Wonderful. Thank you. Dr. Gable.
Hi, thanks. Thanks for inviting me to be on this panel. I am an associate professor at Duke University in adult neuromuscular medicine. I would have to say I really credit my mentors along the way in medical school and residency and fellowship for fostering a love of learning and teaching. And so I like to teach at sort of all the different levels. I find each one sort of exciting in their own different way. I've been for 5 years the assistant neurology clerkship director, and I took over the directorship of that for our medical students this last year. And I've been the neuromuscular fellowship director for 4 years now. And then I also run the resident rotation for 3 months through the EMG lab for our neurology residents. So it's been a really fun experience so far. I've really enjoyed this. So.
Thank you, Dr. Gable. Dr. Khan.
Hi, everybody. I'm Jaffer. I'm a neurologist, obviously, at Emory University in Atlanta, Georgia. So I think I'm probably the oldest here. not by just gray hair, but then also my timelines. I began, I guess, this path when there was no path. There really wasn't a path for a clinician educator. All there was really a passion for teaching. In my journey since, I would say, 97, when I finished residency, I've been a fellowship director for the clinical neurophysiology program at Emory. I've been a residency program director. I've been a clerkship, neurology clerkship director. I have served as a course director for our M1 and M2 neuroscience courses, and actually had just a wonderful honor of being a regular professor in the college, teaching a neuroscience course, a clinical neuroscience course, to very bright neurobiology students in the undergraduate college. And I've done a couple of stints internationally in Africa, as well as Paris, and as well as Northern India in neuroscience, teaching a broad, vast group of different medical students and different college students as well, different in the traditional sense, the Western traditional sense. So my path is just one of joy. It's been one of a little bit of uncertainty. And what is the greatest joy that I see now is we actually do have a formalized path, a formalized way for a clinician educator to move forward in academics, in a field that really has been dominated more by clinician, physician, researchers, as opposed to clinician, physician, teachers. And I'm a tried and true teacher, and very pleased about how I've gotten here and where we are now, and where everybody else on this panel is headed. I think with that, I'll stop.
Thank you, Dr. Khan. Lucy, do we have any questions yet in the Q&A, or should we just start with some of our, okay. So please feel free to ask your questions. I could probably tell you a little bit more about myself, but I'm going to kind of focus on our panel first. So maybe one of the things that a lot of people face are, what obstacles do we encounter in our careers, and how do we handle them? Because the pathway is not always laid out in gold, if you will. And so maybe I'll just give everybody a chance to answer that question. How about I start with you, Dr. Gable?
Well, I would say obstacle. I thought about this for a little bit. I think, when I first started, I think my faculty position, I had a significant amount of clinic time at that time, really a lot. And so it was kind of hard to balance the teaching as well as, with the clerkship and being the assistant clerkship director. So negotiating for time to have the dedicated time for developing some of the coursework within the clerkship and kind of navigating that was an important thing to learn. And I kind of relied on my mentors for that to kind of help negotiate. And I think effectively was able to carve out some time for myself so I could build on the clerkship more with the content. So that was nice to do.
I'm sure you'll hear a lot of dittos and amens. Dr. Flippen, would you like to share any obstacles that you encountered?
Yeah, obstacles. It's always when you are hired to do one thing and then you decide to do another. Then you have to figure out how do you get people to see you in a different light. And so I'm a headache medicine subspecialist. So there's a endless reservoir of headache patients. And so the clinical demands, I had to negotiate the path forward in an education road, down the education road, with my division head and with my department chair, because I was being counted on to do X and I wanted to do or pivot more toward Y. And so, that was, I don't see it necessarily as an obstacle. I just think it was a matter of communicating with people what I wanted to make of my career. And so fortunately, I've had people who've been very supportive, and I was able to make that happen.
Thank you so much. It is really a very important part of what we think we are, what people think we are, and how we evolve and grow in our roles. Because what I'm hearing from many of you is that we all wear a lot of hats, and that medical education doesn't often have a clear boundary. It tends to, well, the students are involved in this and the residents and fellows, and so there's a lot of supports that we give. There was a specific question that was in the chat, so I think we might address this. This goes to Dr. Khan. How were you able to teach internationally? Was it through your university? And if so, how did you create these connections?
Oh, that's a great question. Yeah, I'll back up just a little bit to capitalize on what Carissa just told us, and that is, typically you don't go into this position in regards to a faculty level position in neurology getting paid to teach. And you're going to typically come in with either clinical or research dollars, and that's going to support your salary. And in my case, and probably the same case of everybody on this panel, you come in as a clinician. And this is going to get to your international question, but the core is opportunity. So even though you haven't been given a large role that has any funding or protected time to teach, you should do what you do best, and that is take care of your patients and teach. And so you're going to have opportunities as part of your role as a clinician. You're going to do bedside teaching on the wards. You're going to do bedside teaching and go to the ED on consult service. You're going to see patients in your outpatient clinic center with the residents, with the medical students, with the fellows, and take that opportunity to teach them, and teach them in a way that you feel is best. Have some kind of core reason to teach. Maybe it's that you work with medical students and you want them to no longer fear neurology, right? We all know it's hard, it's detailed, it's difficult. Don't be the person that condemns them for not knowing the answer. Be the person that facilitates learning why a toe goes up when you scratch the bottom of a foot. Be known as a teacher because teaching is in your heart and that's what you want to do. So it's the opportunities that you're given. Seize every one of them. In regards to the international opportunities, there were a few, some formalized and some not so formalized. The formalized one was our college, not Emory University School of Medicine, but our college made a link with Tibetan medicine and the medical school in Dharamsala, India, that was fostered and created, at least in India, by the Dalai Lama. And as a result of that relationship, my School of Medicine got involved in a program where we would send faculty, and they would to India, and then they would send faculty to us at Emory. And I got involved in that just based on my reputation as a teacher and being someone who could maybe go to Dharamsala and embrace a group of astroscience students as well as the Tibetan medical students. And these are traditional Tibetan medical students. So that was a formalized program that I was a part of in its development. I got an opportunity to go with the college, a college student group of 21, myself and one other professor to Paris. I mean, they sent us there for 8 weeks to live and breathe the streets of Paris. And I created a curriculum that compared Charcot's work with modern day work. And we did a comparative analysis in Paris. So created by me and a few others, but formalized by the institution. The third was to go to Zambia. And in Zambia, there's this large teaching hospital called the University Teaching Hospital, gigantic public hospital, the largest teaching hospital in the country. And it just so happened that one of my residents was from there, and not only from there, was born in that hospital. And in our talking, we thought about, wouldn't it be great to go there and do some form of teaching? And we did. We actually put it together ourselves, built our own curriculum. It was very political in regards to Africa and getting in, but she had some family members that were in the government, and we were able to pave our way to do it. We did it on our own, and we actually set up a 1-week program in which we did lectures in the morning with, I believe, if I remember correctly, it was 5th and 7th year medical students in the internal medicine program. Lectures in the morning on the basics of neurology, seizure, tremor, stroke. And then we would go to the bedside in the afternoon and see these patients. And if you imagine, a rural hospital in America with no resources, this was stripped down even from there. And so it was an absolute joy to bring her back there, take her back there with me and live with her family and then teach in the hospital every day. Totally created from spit and bubblegum, if you will. We just did it on our own. So I think if you're creative and if your heart's in the right place, you could make anything happen anywhere in the globe.
Thank you, Dr. Khan. It's really inspiring, truly. I have a question now for Dr. Sarva. What experiences as a resident were most influential in shaping your future role as an educator?
I think the opportunity to be able to teach my juniors and to create simulations for them. I know that one area that we really wanted to shore up, especially for the incoming residents, was to make sure they were running stroke codes well. So we created stroke code simulations. We made sure that there were senior and junior residents who were paired together. So all of those little things, while they may not sound really glamorous, may really make a big difference and help to build kind of your teaching portfolio, because you get to meet and understand different learning perspectives and different learning styles from different people, and it can definitely help to shape your future teaching experiences.
Thank you. There's a theme of questions about promotion and how you can become promoted on a clinical educator, as a clinical educator or as a program director. I have been, like I said, 17 years. I'm a professor of pediatrics and neurology. And because child neurology is actually a division in the Department of Pediatrics at my institution, there is not an opportunity to be a vice chair. So I'm an associate director of education, but there are some questions about that. So why don't we start with perhaps the question about promotion? Let me see if maybe Dr. Flippen, you can answer that as an educator, and maybe tag on to it what your role as vice chair of education looks like.
So thank you. And with regard to promotion, so I actually served on my department's appointments and promotions committee for 4 years. And first, you need to look at your institution. Now, as opposed to probably 20, 25 years ago, all faculty are not the same and not judged by the same criterion, because they're different faculty tracks. And so at my institution, there's a track that is primarily for clinician scientists. And then there is a series that is more for the clinician and more for the clinician educator. And so by virtue of having those trifurcations of career paths, the criteria for reaching assistant, associate, and full professor in each of those series is different, with a different emphasis based upon the focus of the track. So that's probably going to be the situation wherever you're on faculty. I think most universities have taken this approach, recognizing that the days of being a triple threat are past, just because everything moves much faster. You can't really divide your attention like that. And so look at the series that's most appropriate for you to be in. And if you want to be a clinician educator, you want to make certain that you're on the right road and you'll be judged by the right criterion so that you can progress through the academic ranks. And then as far as the nuts and bolts, typically you're looking at how effective are you as an educator? How are those things demonstrated? The reviews that you get of your teaching, the evaluations, awards that you may garner, either locally in your institution or on a regional or national level. Looking for leadership within education. So again, being course director, being program director, clerkship director, those types of roles. Usually for, particularly in more research-oriented institutions, they're going to look for you to have a presence, not just locally, but also nationally. And so that is, are you taking leadership positions on the national stage in various organizations, whether that's the AAMC, the ACGME, those types of positions are helpful in going from, say, assistant professor to associate professor. And then obviously education, scholarship, or creative endeavors. Those things also support and lend evidence to your worthiness of going up the academic ladder. So those are the things, the components of making that progress. And one thing that's helpful is having a mentor. And I think one of our other panelists spoke to the importance of mentors throughout her career. So that's going to be a key part of being successful in academics, and having a sponsor. So, or several sponsors. So you don't just have one mentor, you have a group, depending upon what it is you need help with. And you're also going to need sponsors, people who will put your name in the hat for positions so that you can have an opportunity to lead. And then the second part you wanted me to address was—
somebody asked, what is your role of Vice Chair of Education? What does that mean essentially?
So part of it is mechanic, making certain that everything is running smoothly. And that includes the clerkship, the residency program, and the fellowship programs. And depending upon how your department is designed, it may also include graduate students and postdocs who are on the basic science side. We have that in our clinical department. We have a healthy cohort of postdocs and grad students. So making certain that all of the I's are dotted and the T's are crossed. But also, Vice Chair of Education is more of a strategic planner. Where is it that the education enterprise of your department is trying to go? And sort of looking around the bend to see what's new, what changes do we need to make in order to stay current, stay fresh, and be dynamic.
Thank you, Dr. Flippen. I think you answered a lot of questions. So I did want to say that not every institution has, the concept necessarily of an educator track. And so I do think it becomes more difficult. And when you think about what your body of work is, it really the advice of getting outside of your own department or division, seeing what you can sit on at your institutional level. And then beyond that, for me personally, I think that my roles in being on education committees and graduate education for the American Academy of Neurology sat me in a room with other colleagues and helped give validity to that. So I really suggest that you look at those opportunities. This next question is for Dr. Gable. We have a first attending job this summer after completing their training. This person is interested in teaching both at the medical student and resident level and wants to become involved in medical education. Where do you recommend that they start or seek out opportunities?
Right. I think at the medical student level, I think kind of reaching out to the current clerkship director who probably needs some help anyways, and talking about like different, being willing to lead some of the courses within the medical school, and kind of reaching out to those people who are already directing that to kind of offer your help and to assist them. And at the resident level, it'd probably be the same, just talking with the resident program director, offering to, teach new conferences and kind of offering your expertise, I think would be a good way to just be available and show that you have a love for teaching. So.
Thank you. Oh, okay. Yeah, I wasn't off. So a bunch of theme questions on protected time. How do you leverage a clinical practice, perhaps research with your teaching and other administrative responsibilities? So maybe I'll ask Dr. Sarva to take a stab at that.
Again, it really depends on a number of different factors. So what are your clinical requirements, and what are your division or groups requirements as well? I sort of walked into a position where I kind of have three hats on. So I'm primarily clinician, but my former division chief is very research heavy. So got thrown into movement disorder research right away, and then pulled to also be part of the educational team, which I really enjoy. So it's you could I mean, it's great to have like, medical students around with you and setting up the, outpatient rotations and doing research through Sign. So it's a way to kind of merge both areas of interest. Personally, it's a matter of just watching your numbers and watching your time more than anything else, managing your time, because it's easy to get caught up in sort of this, RVU track and constantly trying to, make up numbers and all these things. But I think once you've sort of built enough equity, you can start cutting back on things and really focusing on shaping your career.
That's such great advice. I think that all of us probably, I don't want to speak for all of us, but I think that most of us, our journey started with us being identified as people who like to teach. And then people who somebody said, we've got this lecture to give. And you said, I'll do it. And then next thing you know, somebody dropped out and couldn't give it. And who's going to fill the gap? And then you're like, okay, I'll fill the gap. And then so it sort of is this evolution of an educator and then a connection. And then you realize, well, this is kind of my thing, but how do I know more about it? And then you maybe dive deeper into curriculum and SWOT analysis and program enhancement and all of those things that make you start to have the nomenclature of what it is to be an educator. So on that vein, I don't know who in our group, I know that Jaffer does have, Jaffer, you have a med ed? Do you have
No, I
a
don't.
master's? Do anybody in our group has a master's of medical education? Okay, so you are talking, so this is actually really cool. We are the little group that didn't. That's what we're going to call ourselves. And because if you went to any of the clerk program directors sessions, the course this morning, there were a lot of wonderful colleagues who did pursue different, degreed programs. And I think that there's probably benefits. Yes, go ahead, Charles.
So I will admit that I have a medical education fellowship that was run through the School of Medicine here. So, but it's not a formal master's program.
I think that, that's such a great point, that many of us understand that we're now diving deep and we want to know more. And so we find ways to get that education through maybe leadership courses. There have been many, many comments in both the chat and the Q&A asking about what programs are available. ACGME has outstanding programs for educators and young program directors, and actually many levels. AAN, if you look, they have programs for early career and mid-career and later career. And, one of the things that we'll say at the end of this is, we're here on this panel, we like to be helpful. We probably have a lot of people in our universes that we consider our mentees and others that we consider our mentors. And so we understand the value of reaching out. So if we don't answer all your questions, make sure that you reach out. We'll give you some great resources, hopefully. There was a great question about how to incorporate medical education in the outpatient setting beyond lectures. And so maybe I'll ask Jaffer, do you want to take a stab at that? How
Sure.
You teach outside of the inpatient setting and not lecture-based?
So there's two things to think about. One is your experience in the outpatient setting. What are the common problems that come up? What are the common questions? And how can you take a multitude of patients that come to you from different avenues and say, hey, look, this is a very, very common question that we're asked. So for instance, seizure versus syncope. You can get that from the ED, you can get that from cardiology, you can get that from primary care, and it doesn't come to you as seizure versus syncope. It just comes to you as a spell, or it comes to you as something happened. But you can clearly see that it boils down to a certain theme. Well, there's your theme to start from. There's your theme to take to the residents and take to the medical students and build upon it in whatever fashion you want. And it may be a lecture, it may be something that you give as a canned response to that theme when you're seeing a patient in the outpatient center with the resident and you're debriefing after the experience. So that's one interaction. Another, which is very nice, if you can do it. And the if you can do it means it's based on protected time. And that may be protected time, meaning time that someone's paying you to do it, or it may be your own time that you're protecting. No one's paying you to do it, but you just do it. Case-based. So one thing we do with our continuity clinic in our institution, in our program, is that at the end of a clinic session with our residents, we sit down for an hour and talk about some of the cases that we saw. It may be a case, it may be multiple cases, it may be the case, what did you see that was very exciting? And then have a case-based discussion. So that is not lecture-based, it's fresh, it's what your residents, or at least one of your residents and one of your faculty saw, and now you're talking about it relatively soon afterwards. Just two ideas of what you can do. There was some conversation in these questions, or a theme in these questions, about protected time. And I gotta tell you, for the most part, no one's gonna pay you to teach. No one is going to pay you to teach. You teach because you love to teach. You teach because you're a fantastic teacher, and you teach because you have the opportunity. And you're probably, I don't see anybody going in and bargaining for protected time to teach, because everybody teaches. Everybody teaches. You can bargain for protected time, which means salary. And when you say that, which means salary, to support your time to teach, if you're a course director or a program director, or you have a certain role. We may see some changes come about in the near future in regards to protected time to teach, but for now, there's not a lot of protected time to teach. So you have to seize the opportunity. You have to build your reputation as a teacher. You got to do what Charles said, which is very important. If you're thinking about a promotion pathway, is not only do it in an institutional level, but then think about the regional level, think about the national level, and think about not just me teaching you, but me showing how I teach, me demonstrating how I teach, me getting involved in committee work at other levels that include those who teach. So you've got to be very creative, very dynamic, and not necessarily get stuck on, well, I'm just out of fellowship, I'm going to get a job. How do I bargain for that 20%, 30%, 40% time to teach? Because at least in my world, that doesn't exist.
Thank you, Jaffer. Very well stated. So the next question that I think is really kind of interesting in the chat is, there's a new attending in a subspecialty clinic. They're doing several community programs and development of programs. And while this is not a traditional educator role, they want to know, what do we think about building patient education programs? And is that something that we would consider as part of our clinical educator path? So for me, this is a harder thing, because there's a lot to do already in my clinical education requirements. And so, but I'm still a clinician, like I'm still an epileptologist. I still care about the things that my own program. So that's sort of how I think of it when I'm doing parent education, or I say parent all the time because I'm a pediatric neurologist. So forgive me for that. But whenever we're doing patient or parent education, it's usually more, I think of myself as a clinician at those times, not as a medical educator. Does anybody feel differently, Harini?
Yeah, I think there are definitely opportunities, and you can actually even use that to build your portfolio as an educator. So for example, we did a couple of projects in our group where we used tablet-based surveys to teach about core, Parkinson's topics, or, other topics. And we did a pre-test and post-test, and sort of said, well, what are we doing? How are we doing in terms of teaching our patients? How can we improve? And what do we need to kind of focus on going towards the future? The other thing is my nurse practitioner, and that's where, it's great to have like APPs in the practice as well, has sort of developed a community outreach lecture series. So there's a way of, being an educator, not just for medical students and residents, but for the general public, which may also include, advanced practice providers, et cetera. And there's a lot that you can sort of build your profile that way.
Such a great point. The hospitals are full of opportunities to teach. Our clinics are full of opportunities to teach. And it's very much outside of the narrow, maybe trainee that we think of. There was a great question about, what are our experiences, successes, or setbacks with publishing your medical education endeavors? So who would like to take that question? Maybe Carissa, do you want to tackle the publishing your medical education endeavors?
Sure. So I think probably the thing there would be going back to sort of having a national presence, like being on committees where you're collaborating with a lot of other people, because ultimately you're not going to publish that on your own. So I think sort of using those connections with others who are interested in sort of looking into questions that you might have within that come to you, like how are the medical students studying for their shelf exam, and what are the most effective, like, resources that they can use, and how would you, like, design a study surrounding that, and you can kind of discuss that with internally at your own institution, or even make it broader. So some of the publications that I have been more or less collaborative, like I think through subscribing to the program director kind of AAN blogs and kind of following along with them, and that kind of, I guess, coming up with your own questions to publish, but also kind of collaboration would probably be the two things that I think would be the most effective way to publish in that area.
Great. Anybody else have another comment on that? I love the idea of collaboration and the value of being on our synapses.
I think
All right, we'll do both, because this is a really good question. So Harini answer, and then we'll have Charles.
okay.
Going back to collaboration. So I started collaborating with people in the A.B. Baker section. And that was sort of how we came about a couple of projects with regards to the flipped classroom and EVUs and things like that. So that's a good starting point and stepping stone. And also the synapse, they're always like, possibilities for collaboration there. And I think, I just sort of harped on one of them and said, yeah, I'm happy to help with that. And that's sort of led to several other publications. So that, like I said, just take advantage of your opportunities, and there are multiple avenues to do that.
Charles.
All right, thanks. One thing I think you should really do is be strategic of where you are going to submit your manuscript. And that's, working with other people, you pool your knowledge as to the type of work that you're doing and where is it going to be best accepted. And just remember that there are journals that are specifically targeted toward education. Academic medicine, great place to get your work published. Fortunately, the Green Journal also looks for manuscripts looking at education techniques and advances in medical education. But you really want to look at those, at the journals, and then look at the sort of flip through them and see the types of things that have been published before. That way you'll know if you're going to be in their catchment area for approval. But the community of educators, we're all working together. We're all trying to make certain that the field continues to grow and be viewed as an important part of the profession. And so you're going to have a lot of support there. And fortunately, you can reach out to, I think, across the board, people who serve as section editors for education manuscripts are willing to take your email and say, and you can just ask them, does this, can you give me some advice on this? What do you think about this topic? I've never had anyone not answer an email.
And I'll add something that I think both those comments were great. Charles mentioned something earlier that I think is very important, and that was about promotion, and I'll take it to research and publication, and that's the impact. Your goal should be, in one way, to measure the impact of what you did. And you could create something that's descriptive. I saw this, I did this, and this was the impact, and publish that. If you're going to go to a really high-end education journal, you need to realize that you're going to compete with PhD med ed people. And that's not what I am, and most of us aren't, but someone brought up the Masters of Medical Education before. You may want to link either with someone who has it, or you may want to get it yourself, because you really do want to think about the science of medical education. And with going back to Carissa's collaboration, yes, collaborate. If you're a program director, a residency program director, or a clerkship, you're a director of one, get 10. Get 10 across the country that are facing the same issues or have the same desires that you have, and then get someone who really knows the science of medical education to explore your idea and then put it into a very structured and scientific, rigorous, critical way of producing the outcome, as opposed to something that's more descriptive.
Thank you, Joffrey. There was another question, actually, this one's sort of for you, since you're talking. Could you comment on your transition and involvement with ACGME and how this differs from your previous roles? And are you on the dark side? No, that was.
No, that's good. I like the way you phrase that. And we're going to get Charles to speak up too, because he's been a partner in crime, so to speak, for many years with me on the committee. And he precedes me actually on the committee. But let me back up to my role as a program director. First, I was a clinical neurophysiology program director. And I want to tell you, I viewed my own GME office at the institutional level as the evil. I was afraid of them. I didn't want to explain anything to them. I didn't want to expose myself to them. And it didn't take much time. I ran that program for 12 years. I ran the residency program for 10. And I realized, no, they're not evil. No, they're not out to get me. Actually, they're nothing but benefit to me as a program director, because we all have the same goal. And that is to maintain an accredited program that produces the best and brightest, in my case, our case, neurologists that our programs can produce. And to produce medical students that have a foundation of what neurology is, irrespective of what field they go into. We're on the same page. When I got to the ACGME, I think I was still a program director at the time, and I had that same feeling. It was like, oh, it's the ACGME. Again, it's that dark side, it's the enemy. They're the ones, and very, very quickly, well, maybe it took a year, I realized that no, as an RC, Residency Review Committee member, actually, we're doing the same thing. We're trying to ensure that programs are complying with national standards for training so that our residents can get out and be the best and brightest competent residents practicing the unsupervised field of neurology when they're independent. And so the transition, it was a little rough, at least from a viewpoint perspective, but the learning curve was very, very sharp and steep. And we are all in this together, and it's an important body to have. And so I will say now, I'm in I think my 5th year. Charles, you just ended your 6th year, so then I was a year behind you, so that means my 5th year, and I have 2 more years to go in my role as chair. So it's been a wonderful learning opportunity for me. It's been a wonderful way for me to engage in what's going on in the United States in regards to programs and the issues they face. And I'm able to carry that information into other venues, whether locally or nationally, and say, hey, we have these requirements and we have these issues meeting those requirements, and it's not uncommon. How can we break down those barriers so that either the program requirements change or the programs are able to meet the requirements? So it's been a wonderful, wonderful transition and time that I've had. Charles, I don't know if you want to give some comments as well.
Serving on the review committee is a great honor, pleasure, a lot of work, but you do see that this is not about Big Brother trying to crush people. We agonize over making certain that people are getting the resources that they need so that they can run the best education program that they can in their institution. It lets you also know that there's a lot of thought put into what we do and what we're asked to do as program directors. It is very informative, and hopefully people, when they engage with ACGME, they understand that it's there to help, and really that should translate to your institution GME committees. Your DIO is there to help. Everyone wants education to be the best it possibly can be, that our learners enjoy the process. There's some struggle with education when you go from novice to proficient to expert, and that's just a natural part of learning anything. But really, there's a lot of thought put behind making that process as seamless as possible. That's just one organization, national organization, that you can become active in. And you don't have to be necessarily on a review committee. There are many other committees and subcommittees that you may become involved with within the under the ACGME umbrella.
So I might add one other thing, Charles. I agree with everything you said. There was a question in the Q&A regarding my comment about the future of protected time to teach. And so let me add a little bit, maybe not. Sorry about that. So there was another question about that. And so the ACGME not only creates program requirements for our residencies to subscribe to and to be compliant with, but also looks broadly at all the issues we face in graduate medical education. And so, for instance, 5 years ago, they put together what's called a Congress about duty hours and came together to look at these duty hours that were set forth and what are the outcomes from it? Are they really helping? Are they not helping? Are they helping some specialties and are they inefficient and not working for other specialties? And the ACGME came together and modified the duty hours. Well, this past, I would say, well, almost this time last year, the ACGME Board of Directors came together and said, we need to look at protected time. We need to look at protected time for program directors, as well as associate program directors, as well as program coordinators, and as well as teaching faculty. And so a task force was put together at the request of the Board of Directors, and that Congress was held last November that requested written testimony and verbal testimony from not only the RCs, the review committees of residencies, but also our specialty organizations, our member boards. So in our case, the ABPN. And I would say there were probably over 200 stakeholders that actually commented on, should we have protected time? If you're a faculty member, not a program director, not a associate program director, but core teaching faculty program or faculty, should you have protected time? Meaning time set aside in your 40-hour, 80-hour a week, whatever it is, to allocate to teaching and the administration of your teaching, evaluations and mentoring and things that you do. And so those recommendations have now gone to the Board of Directors and have now come back to the level of the review committees for review. And we may see in the future that an ordinary teaching faculty may have some component of protected time. I don't know if it's going to go through, but we'll see. And so that was my reference. And I think that folds in nicely with the ACGME being a body that, whether you like it or not, is there. But the truth is, I have learned a very important body for us to have.
And really what we know by having Charles and Jaffer here is that they are us, they're not some nebulous them. They are here among us today, and they advocate for us, and they know what it's really like in the day-to-day. There's a nice group of questions about young faculty or young residents who want to get involved in teaching. I think we've talked about it in various ways, but let's just narrow in really on that first career faculty member or resident who's starting their journey, and how can they get involved in teaching? Harini, can you take that one?
One thing that would be good to ask is if your program has a resident as teacher track, or if there are specific mentors who are focused primarily on medical education, and see what you can get involved with there, whether it's education research project or specific lectures that you can give to medical students as a resident or to junior residents. As a first year faculty member, I think I got involved in pretty much everything. So resident lectures, resident clinic, student lectures, brain and behavior courses. I mean, that's how you sort of build your experience in your portfolio as an educator, and then kind of see where you want to go from there, whether you want to just focus on medical students or residents or a little bit of both. That's probably what I would recommend the most, is just cast a wide net early and gain as much experience as possible.
You know, such great advice. The program directors, they're always looking for great core faculty. Clerkship directors are always looking for faculty who want to teach. And so I think that's a really important way to get through. I also teach at our university's brain and behavior course. I'm not going to be Pollyannish though. I think it was really hard for me to get in. You know, it was a old group of people who'd been doing it for a really long time, and they weren't really that receptive to me knocking on the door. And then I knocked on the door and I knocked on the door, and finally leadership of the brain and behavior course changed, and I didn't actually realize it. And then they came knocking on my door, which just goes to show, just keep being an excellent educator, put yourself in the opportunities that you can. And sometimes, you know, things happen, people leave, they move, you know, they retire, and they still need you. And so don't sever relationships because in the beginning it felt a little bit complicated. You know, so as we all sit here and talk about, we're all teaching on these courses, the path wasn't always straight. Many questions about protected time. I think we've addressed the time. If you have a funded position, or, you know, if you're in leadership, we now have clear guidelines. We use that, we hold it, we take it to our chair's office, we take it to the dean's office, and we use it to negotiate. Everything else I consider, as a leader in education in our division, that's my job also, is to lobby on behalf of my core faculty who are doing an amazing job, or other people who are doing more of a leadership role. And I think sponsorship, you know, give people titles. Don't just have them be the helper. If you have a committee, create it, form it, put somebody in charge of it, put some people under them, and then they have a formal role. And if you are doing a role that maybe could be formalized, go to your education leadership and say, you know, I mean, I keep doing all this stuff for recruitment, but I don't really have could I chair your recruitment committee? Or we don't really have a diversity policy, or, you know, what's holistic review look like? Let me take ownership of that. And that's what a good mentor and sponsor will do to amplify others around them. This doesn't necessarily fit in our wheelhouse 100%, but somebody asked this question. It's hard for me to ignore as a medical educator, about if you witness experiences of hazing or inappropriate being treated. I think I'll just quickly take that, which is, you have to keep people safe. You have to know that they're heard and validated. And if you can't reach out to someone because it looks like you're a student doctor, then there's anonymous lines. You should just go to the next step of command. But, and if you're not safe, the university has an anonymous line for the DIO, and please do that. You know, please be safe. I'm not exactly sure what your circumstances are. And if you want to reach out to me after, personally, privately, we can help walk you through that. So in the last 2 minutes, there was a final comment about somebody who's maybe not in an academic institution who wants to be involved in teaching. And so does anybody have any suggestions for them?
Well, I think it's who do you want to teach? Because I think that you can find opportunities to teach in a variety of settings, not necessarily within the structure of a formal residency program or clerkship. We have a cohort of community neurologists who are voluntary faculty in our department, and they supervise residents in the continuity clinics. So they have an opportunity, that's an opportunity to teach. I think also looking at the continuing medical education realm, that's another opportunity to teach, as was mentioned earlier, teaching the public. Tremendous opportunity to teach, because we, you know, I think if nothing else, this past year has really demonstrated that we need to raise the level of health literacy within the nation. And so there are plenty of opportunities to teach there. If you want teaching for credit, then I think it's a matter of looking at what is offered within your institution as far as outreach is concerned, for pipeline programs, for CME, for the lay public. When I was faculty at Indiana University, they had something called mini medical school for the public, and you could do lectures to groups of interested citizens on a variety of topics. So there are a lot of avenues for teaching outside of those very what we think of traditionally as the avenues and venues for medical education.
Thank you so much. It's 4 o'clock, well, 4 o'clock my time, I guess 5 o'clock somewhere else. Dr. Fauci is about to talk, and so I don't want anybody to be delayed, but thank you so much to the panel. I really was such a great, I learned so much from you, and I hope everyone else did. I appreciate your participation. It was such a great Q&A, and come see the live if you have other questions, and have a great day. Don't forget to do the e-posters. Lucy, I promise, Lucy. All right.
Thank you.
Bye-bye.